Colonoscopes are longer and mostly less stiff than gastroscopes. Up to 30 centimeters from the tip, all colonoscopes have floppy pediatric characteristics, and the bending section is longer than a gastroscope's to avoid impacting at angulations. Otherwise, the air-water and suction valves, the angulation controls and switches are all the same as on a gastroscope. There's a carbon dioxide connection on the umbilical or the water bottle, and older scopes have a connection for a lens flushing syringe. Standard colonoscopes are around 13 to 15 millimeters in diameter, with instrumentation channels between 3.2 and 4.2 millimeters. Larger channels help suctioning residue or blood clots and are easier for passing dilating balloons or decompression tubes. Colonoscopes and gastroscopes differ in that their instrumentation channels are on opposite sides relative to their viewing lenses. This endoscopic view shows the colonoscope forceps emerging on the right, in contrast to the gastroscope where they emerge from the left. Conversely, colonoscope insufflation bubbles on the left, but gastroscopes on the right. Compared with standard long colonoscopes, the pediatric colonoscope is shorter at 130 centimeters, around 1 centimeter diameter, with floppy shaft characteristics and a shorter bending section. This makes it easier for passing diverticulosis or strictures, but more difficult to reach the cecum in long, mobile colons. The acute angulation of a pediatric gastroscope can sometimes be better still in severe diverticular disease. The magnifying or zoom colonoscope has either a twist control, a thumb control, or a foot switch to zoom the view. This gives better resolution of surface detail, especially if dye spray is used to enhance the surface view. The up-down angulation control knob is managed by the thumb, but it is possible for single-handed steering to stretch the thumb across to reach the lateral angulation control also, at least for small movements. Altering the hand grip a little may help those with smaller hands reach across to the lateral control, rather than always having to use the right hand for lateral steering in the two-handed steering approach. The up-down brake is very rarely needed, perhaps during a difficult polypectomy. The lateral brake is more often used. Angulating with the brakes on does not damage them. The air-water valve leaks air into the room until the hole on top is occluded by the finger, transmitting air pressure down the scope and insufflating the colon. Water wash of the lens is activated by pushing the button hard down, then waiting until water squirts the lens. The water bottle must have water in it and is pressurized by air entering the water bottle at the cap. The water bottle cap must be screwed on tightly to allow air pressure to drive water up the tube through the air-water connector and into the scope to wash the lens. In older scopes, the flushing syringe is a less elegant but quicker way of washing the lens. Pushing down the button of the suction valve activates suction, but the channel opening at the tip must be orientated at 5 o'clock at the top of the fluid for efficiency. If necessary, rotate the view to position the channel properly and always try to suction under direct vision, judging the time of button press according to the amount of fluid to be aspirated. Suctioning underwater, or with the tip too close to the bowel wall, tends to suction the mucosa, leaving a suction bleb behind, which can be mistaken for a polyp, but disappears on waiting. Suctioning the surface can also be done on purpose to show the patient what a 3 mm polyp looks like. Of course, it disappears quite rapidly. Suction blebs can be released by lifting the biopsy cap briefly to let in atmospheric pressure. The cap has a push-down flap with a slit in it, which can be damaged by accessories or by washing through it with a syringe, and can then leak air or fluid or let in air, losing suction pressure, and so needing replacing with a new one. The light guide plug at the end of the umbilical contains not only the light guide connector, but also the air connector, so it must be pushed firmly in to avoid air leakage as well as to get proper illumination. The water bottle connector on older scopes simply pushes in, but watch out that the rubber O-ring is in place or air will leak out, and also the water bottle won't pressurize. Newer scopes avoid this problem with a push and twist connector and have no O-ring. The electrical connector of video endoscopes also has a twist fitting. To avoid damaging the CCD chip of the scope with a power surge, it's very important that the processor is switched off before the connector is joined up, and switched off again before disconnecting. As well as the usual controls, video endoscopes have programmable switches able to control various functions and labelled 1 to 4 from the top of the scope down. The switch's function can be changed to individual requirements, on screen with the keyboard in newer scopes, or by adjusting small dip switches at the back of the processor in older scopes. Most endoscopists do use the freeze function to ensure picture quality before storing an image. Not so many make use of the so-called iris function, which can avoid flare-out by too bright reflections, adjusting for the overall average illumination or the peak or brightest area as required. The image enhancement function, set at 2, little enhancement, 5, moderate enhancement, or 8, maximum enhancement, can be attractive, for instance when imaging polyps or fine detail. If insufflation fails, check. Is the air pump switched on, or the CO2 cylinder on and full? Or has the umbilical pulled out, which disconnects the air supply? Is the water bottle cap screwed on tightly? In older scopes, is the water bottle connector pushed in and is there an O-ring present? In newer scopes, the twist connection avoids this problem. Is the air or CO2 valve fully pushed in? Or is the button stuck down, needing to be pulled up again and removed for lubrication or a replacement valve fitted? Is the biopsy cap missing, which lets the colon deflate, or is it damaged and leaking? If none of these checks finds a fault, there may be a blockage at the scope tip. Try forceful syringing with the channel flushing device. If all else fails, as an emergency measure, emptying the water bottle of water and using full pressure on the water button will then insufflate air successfully down the water channel. If water wash fails, and there's water in the bottle, check that the cap is screwed tightly. Then temporize, either by using the flushing syringe on an older instrument or using the channel flushing device, if that's available. As a last resort, it is possible to syringe flush up the water bottle tube, remembering to push the water button at the same time. If suction fails, but suction's audible at the scope, release the biopsy cap to free any mucosal suction bleb. Take out the suction valve and try occluding the hole with a finger, which should free any debris in the channel. Next, take a 20 cc syringe and flush water down into the colon, which should clear the channel. If suction fails and isn't audible at the scope, check that the suction has been switched on. Then feel directly on the suction tube. Is the vacuum arriving at the scope? If there's no vacuum, is the suction tube kinked or the suction bag full or faulty? If there is vacuum, is the suction button jammed down? Or is the suction valve blocked or faulty, needing replacement? If all checks fail, the final resort is to water flush back through the suction port on the umbilical with a 50 cc syringe, either removing the suction valve and flushing into a container, or with a finger over the suction valve hole, flushing all the way down the channel and back into the colon.